Hello, everybody. I'm Dr. Fernando Borges, a Brazilian urologic surgeon. And today I'm talking so far away from my home, directly from Dubai in United Arab Emirates, where I'm doing a short fellowship in regenerative andrology. Today, we not have just another simple interview. We have a meeting point between science, innovation, and the future of the sexual medicine and your impacts on men's health quality. I'm truly honored to have here with me one of the greatest names in global andrology, a high-impact translational researcher with more than 500 indexed scientific publications and over than 7,000 citations worldwide, and a reviewer of most high-impact urologic journals. He has been among the first urologic specialists to research and discover the impact of COVID-19 on male infertility and erectile dysfunction. Among several prestigious awards, he was received in 2023 the Gold Cystoscope Award from ADUA, a very important scientific acknowledgement for creative, impactful work in andrology, mentorship, clinical scholarship, and research files. An absolute reference authority in male sexual medicine focuses on erectile dysfunction, peritoneal disease, male infertility, and regenerative therapies, PRP, shockwave therapy, stem cells, and exosomes too. If he's not the number one worldwide name in andrology, at least he's the youngest and the most friendly of them all. Then now I can call off my friend, Dr. RAMASAMY. Welcome.
Thank you. Thank you very much, Fernando.
Even with your high-impact trajectory, for those in Brazil who don't know you yet, who is Dr. RAMASAMY in personal level? Talk about your family origins, where you are born, how was your childhood, and how did you become interested in medicine and specifically andrology? Did you have any mentor or any special motivation to choose this way on your career?
So I grew up in India and grew up in India throughout high school. And my family had the opportunity to move to the United States when I finished high school. And at that point, I could take two paths, and one to stay in India and to finish medical school, or to move with my family and stay in the United States. Even though I had an opportunity to stay in India, I chose to go with my family to the US, even though I knew not becoming a doctor was a real possibility. But went on to start my career in New Jersey at Rutgers as an undergraduate student, and then stayed on there, fortunate enough to get into medical school there, stayed there, and then did residency at Cornell in New York, where I was fortunate to meet very good mentors in male infertility and in andrology. And I've always wanted to choose a surgical field. I knew I was going to be very good in surgery. I liked being in the operating room. But at the same time, I didn't want to spend my entire career and life in the operating room, and I wanted to have the connection with my patients. And urology offered a very good opportunity as a good blend between both medicine and surgery. And within urology, I felt andrology and male fertility and sexual medicine was sort of an afterthought. People didn't know much about it. People didn't want to go into it. The smart and the bright ones in urology were not entering into that specialty. And so I said, why not explore more in this? Because at the end of the day, trying to help men with quality of life, with both their sexual life, reproductive life, was also equally important compared to just the quantity of life that we are able to offer in so many other specialties in medicine. So then I went on to do a fellowship at Baylor College of Medicine in Houston, Texas, where I truly became interested in translational research, basic science research, and tried to understand how we can translate science from the bench to the bedside. And then I found a very good opportunity in Miami, where we started one of the first andrology fellowship programs in the southeastern United States, and was probably led to a majority of my impactful and translational and probably paradigm-shifting research that we were able to do in my first 10 years. And then now, having moved to Dubai, wanting to be closer to family, back in India, we feel like we're now able to move the field more forward, because some of the specialties within some of the research possibilities that I could not do in the United States, we're now able to offer here in Dubai like stem cells, exosomes, and some of the regenerative therapies for both severe male fertility as well as sexual dysfunction are able to be offered here. So very exciting time in andrology. And so very happy to be here and discuss all of the innovations and the developments that we can do in the field.
I know that you recently moved from Miami to Dubai. And what motivated you to do it, and how do you balance your clinical work, research, teaching, and personal life today?
So one of the important things for us as clinicians to remember is we often try to put silos. We try to put clinical time, research time, teaching time, and try to separate these into different buckets. I think we should not do that because we truly don't have as many hours in the day to try to fill all the buckets. And usually the clinical bucket gets filled first because obviously that's revenue generating, and research and teaching all come as an afterthought. And if we have time, we do that. And if we don't have time, that sort of gets shifted along. And this is probably true in most clinical disciplines because remember, we went into medicine to take care of patients, and we went into surgery and urology specifically to be operating and to be fixing problems. And so if we do not fulfill the task, we feel some sort of incomplete, inadequate feeling. And so we fill that bucket first, and then we allocate time for everything else, and sometimes including family as well. I try not to do that. I try to think about research projects while we are seeing patients. I try to think about teaching and passing on knowledge while we are discussing research. And so I don't think we should be thinking about these as separate buckets. I try to think about work, and I try to think about family. And those are the only two buckets I try to fill. And with comes work, tries to come all of the research, clinical aspects, and the teaching aspects. And then with comes family, I try not to mix work and family. That is also difficult sometimes, but I try to keep those two buckets separate.
That's the reason that I changed my focus of my career to I am a urologic surgeon, oncology urologic surgeon. I love surgeries, hard surgery, long time in operation room. But then when I comes to 40s, then I was in burnout, healthiness trouble, almost 100 kilos. Then I need to, how will you balance my time and my life, my health life? Then I think, but I still need to make money. I still need work. But with surgery, I think I will die. I will die too fast. Then I start to study and focus my career in andrology. Then that's the reason that I'm here today. Right. And I'm so pleasure to be here with you. Let's go. If you could go back 20 years in the time, what would you do differently that you told me right now?
I don't think I would have done anything differently. I think the one thing that I would have probably done, and I think as clinicians we all have some sort of regret with this, I would have probably spent a little bit more time with the family. Tried to keep family and work a little bit more separated, and try to see if we can somehow balance that a little bit more. As far as career and trajectory is concerned, I think it's a very fulfilling career to be as a urologist. It's a very fulfilling career for you to come into andrology and to share some of the joys with the patients, be it a very happy sexual life, or be it very happy reproductive life, being able to help couples father a child, to have a child. I think all of that is very fulfilling. So in terms of career, I don't think I would have done anything differently, but I think I would have definitely spent a little bit more time with the family, which I am doing now, having moved to Dubai, and tried to keep work and family more separated.
I agree with you in these questions. Andrology, it's a great area in medicine that we can do surgery, we can do consultants, and we can do everything we want to do.
Correct.
For the whole life. Which study most impacted your career or lead to changes in clinical practice worldwide?
So I think there are a few studies which have changed, but I think one of the studies that we published, I think back in 2009, where men with COVID vaccine. We're trying to say that the vaccine actually causes infertility. And we were the first ones to show that the vaccine has no impact on sperm parameters. And this, I think, truly helped both the public health cause as well as help the community at large not have this fear about vaccines causing infertility. It was really the COVID virus that caused decreased sperm counts and infertility. It wasn't the actual vaccine. So I think that is one study that I'm truly proud of that was able to change how we viewed vaccine acceptancy when COVID was such a terrible illness and vaccine was saving people and didn't really cause that one particular side effect, which was infertility.
I heard a podcast that you record about this topic, and you published this study very early in the, I think, less than 1 year.
Yes.
The pandemic explodes. How do you do this too fast?
Yeah. When COVID was around, and before we got the vaccine, COVID was identified in many organs. The early studies had shown that it was present in the kidney. There was 1 or 2 studies that showed that it was present in the heart long after the infection was cleared. And I asked myself the question: if COVID is causing endothelial dysfunction, it can be present in the reproductive organs because there is endothelium both in the testis as well as in the penis. And we were the first ones to show that the virus can be present in both the testis and the penis long after the infection was cleared. So we had shown that COVID was impacting both erectile dysfunction and male infertility. And when the vaccine was launched, people just assumed, and nothing wrong on their part, to think that the vaccine was similar to the virus. And because of this misconception, we automatically made the conclusion that if COVID virus would cause male infertility, the vaccine would also cause male infertility. And so when the vaccine was launched, we quickly had to do that study to show that the vaccine, which was just a small piece of the mRNA of the actual whole virus, did not have the entire elements of the virus that would cause male infertility, but just the small piece of the mRNA to show that it will not affect sperm parameters. And as soon as the vaccine was launched, I think we had launched the study at the same time to show that it had no impact because of the urgency in which it had to get released. There was not enough time for both Pfizer and Moderna to actually do the study to show safety for sperm parameters. And so we took it upon ourselves to make sure that the vaccine did not impact infertility.
That was too fast, and the world was afraid. That was a panic with vaccine and too many conspiracy theories. Yeah, we suffer with this in Brazil. It was, I think, all the
worldwide.
all
It
the
was
world,
worldwide. There were a lot of celebrities that said that the COVID vaccines could affect infertility.
celebrities, politicians,
Correct.
important persons. That was a great nightmare.
Yes.
Thank you for your
Yes, thank you.
This is a legacy.
Yes.
That you wrote in the history of COVID.
Yeah.
I think that's it.
No, it is important. I mean, it was published in JAMA, the Journal of American Medical Association, and obviously one of the highest impact journals that we still have to date. And I think the article was viewed over 1 million times. And there's a very few articles in entire medicine that get viewed more than 1 million times, and this was fully worth it.
That's it. Congrats again.
Thank you.
Despite the rapid advances in medical technologies that have increased life expectancy, we are now facing a global pandemic of obesity. In USA, over 7% of the population, and in Brazil, over 60% are overweight or obese. This directly impacts male sexual health by increasing cardiovascular disease and erectile dysfunction, as well as being the main factor of the most cases of male hypogonadism, symptomatic low testosterone levels, that are described like MOSH, M-O-S-H, that we have reported in the last 20 years. What do you think about the potential consequences of this epidemic of hypogonadism in this modern man, not only in terms of sexual health, fertility, and virility, but especially regarding the non-sexual impacts such as fatigue, depression, low energy, and lack of motivation of anything? What do you think about it?
So obesity, I think, is is definitely a pandemic. It is not just a United States issue. It's not just a Brazil issue. It's not certainly a Dubai issue. I think it is a worldwide issue. And I don't think the problem is going to get any better anytime soon with the advent of fast foods, of how easy it is, how cheap and sort of inexpensive it is compared to healthy foods. As long as we keep unhealthy foods inexpensive and healthy foods like salad, fruits, and vegetables expensive, I think we are almost never going to change this equation of obesity and solve the problem on its own. And so, obesity will continue to remain a problem, at least through our generation, maybe through the next generation, if we as a society don't really change this paradigm. In terms of how prevalent it is and its long term impacts, I think it's a significant issue. We, I think, as a population, have been looking at adult obesity, wherein we get overweight and obese when we become adults. But I think the bigger crisis and the bigger worldwide issue that we are not discussing as much is adolescent and young adult obesity. Kids who are now between 12 to 21 years old who are obese and or overweight, I think will have very long-term consequences when it comes to both sexual health and reproductive health. What happens during 12 to 21 is puberty. This is when male testosterone gets produced, women start getting periods, estrogen gets produced, and this is what drives both sexual function and reproductive function, are both testosterone in men and estradiol in women. And during this critical phase between the ages of 12 to 21, right after puberty, if obesity is present, there will be lifelong consequences because of the heat that happens in men, where there is now testes need to be cooler for both sperm production and testosterone production to happen. But both of them are now hampered because of the obesity and the functional hypogonadism that you discussed with MOSH, MOSH. And therefore, long term, both erectile function, reproductive function, and metabolic diseases will all be absolutely affected, leading to long term consequences that we still don't know completely yet. And we have yet to discover them as we get older, but I'm fairly certain this will continue to remain a problem, not just in our generation, but in many generations to come if we don't fix the paradigm of how inexpensive fast food is versus expensive healthy food.
That's it. Another important factor that contributes to this statistics is the use of agrotoxics and pesticides. When we see a word map about the low level testosterone, we see clearly that the Americas, North America, South America, and Australia, they are the leading the ranking of the low testosterone levels of the world. This is a great factor too.
Absolutely. I think we still don't know why most men have low testosterone, low sperm count. Most of them are actually in the unknown bucket. And so factors such as pesticides that are being used, how crops are being raised, how meat is being produced, antibiotics that are given to animals and birds that to make more meat, to make faster meat. I think we still don't know the true consequences of these. I think one of the things that you're alluding to is endocrine disruptors. With both microplastics that we are now exposed to, both in the diet, from the seafood, from plants, that are long present in the human body after we even stop using it or consuming it. So I think when we look at environmental factors affecting it, I think they play the biggest role, because such a sharp decline in testosterone levels, sperm counts that have happened over the last 10 to 20 years cannot be explained by genetics. It has to be explained by environmental factors such as these.
So you mentioned the cost of healthy food nowadays compared to fast food. So, in your opinion, between making healthy food cheaper or developing new obesity medicine, which of these solutions would be more efficient nowadays?
I think one is a potential cure, the other is just a treatment. So, obesity medicines and developing drugs to treat obesity is just a simple band aid. People who are taking the drugs will lose weight while they're taking the drugs.
And they'll get the weight back.
And they may gain the weight back when you stop the drugs. Whereas if you actually change the paradigm of how we make healthy food less expensive and more affordable, I think that's a potential cure where we may not even need to get to the disease of obesity and think about treating it. So, yeah, if you give me the two options of should we invest more money in developing drugs to treat obesity versus should we invest more money in trying to make food that is healthy less expensive, I think we should absolutely invest more money in trying to make healthy food less expensive.
We know that the lifestyle is a very impact factor. Né? Our activity,
live.
functional, our distress conduction. That the world today is very fast. Too many screens, too many things doing at the same time. This too many dopamine stimulates. The world is against our testosterone levels. I think the I call this like a phenomenon that the extinction of the man in the modern era. The extinction male of the man, modern man. That's I can say that.
Absolutely. I think we in this generation are used to getting and needing everything right away. We call this the insta generation. We want to lose weight tomorrow. We want to gain muscle tomorrow. We want to look good tomorrow. Because we are used to this aspect of we need everything instantly. We don't realize all of the harm that we've potentially done over all these years, and we expect a miracle cure to happen tomorrow. And life doesn't work that way. If you have spent all these years in a state of obesity, you've never gone to exercise, you've spent all the time on devices, and you've led a sedentary lifestyle, you need to go back and put back all those time to go back and becoming healthy by reversing all of the things that you've done. And it's going to take equally the same amount of time. And so that's why these drugs, GLP-1 agonists that offer a potential quick fix are not a long-term solution. I think we just need to make sure that we can change our behavior while taking these GLP-1 agonists and drugs so it can last for a longer time as opposed to just a temporary fix.
I think that it will be a balance in customers, and this is still happens. We need to take a back steps and the velocity and a step backwards and in our velocity. That I think that our body, our specimen, like man, we are suffering high impact of the lifestyle. We don't know what we'll do if we don't make any change, important change in lifestyle. That's the way that you need to do.
I think that step back that you mentioned, I believe it started with, a few years ago we had that fever of organic food, and now everything has to be paper straws and everything. I think that's where it started. We're taking a step back into rejecting modernity in some way, I believe.
I think it's absolutely important because if we continue down this path, we don't know where it's going to take us, right? So yes, it's difficult. My kids don't like paper straws. They tell me they don't want to get paper straws from Starbucks because the paper gets clogged in the thing and they cannot drink the coffee.
We relate to it
properly. So yes, did we take a step forward by abandoning plastic straws and by using paper straws? Yes, I think we have, but it comes with inconveniences, But the problem is we put the coffee in a plastic cup and give out a paper straw. And so the amount of microplastics that is being consumed from the plastic cup is probably the same as what would have been in a plastic straw. And so, yes, I think we're trying to take steps forward and we are trying to at least increase awareness. But I think we still have ways to go before we can go back to the days of our generation where we drank coffee from a regular cup and we washed it and we did not throw it versus like drinking, coffee from a plastic cup, especially hot coffee that gets poured into a plastic cup. Of course, the plastics are going to melt. Yes, we give a nice paper cup of coffee, but then we put a nice plastic lid on it. And so the hot coffee and the steam melts the plastic off of the lid that enters into the plastic. And we sip the coffee with a plastic lid. And so the hot coffee, as it gets into our mouth while we are drinking it through the plastic lid, of course, is sending microplastics in. I think we've taken society very far, very fast, where we wanted convenience. We wanted inexpensive, we didn't want to pay for it, and we wanted to lead a convenient life. And so now we're just paying for the convenience. We need to go back and figure out what are some of the inconveniences we can accept, like drinking from a plastic straw and some paper melting while you're drinking it, and what conveniences we can forego.
That's it. I think the enemy is in everywhere in the new age, but it's difficult to fight within. But we need to know who and what is our enemy. Just to know, you need to know your enemy to try to fight it. Right. But the most people don't know this is our enemies of our health. How could this lead to a generation of young men with less drive to study, work, and succeed in life? And what implications could this have for modern society?
So now we're seeing a generation, and this is not just a young men issue. I think we're having a lot of, it is a cycle that is feeding itself with both men and women. We see lack of motivation to do anything these days. It's not just go and exercise, go and eat healthy food, go and lead an active lifestyle, go and lose weight. It is lack of motivation to do work, to succeed in life, to work hard and make sacrifices so you can move forward in life. People are often thinking that things will be gifted to them and given to them. And I think as a society, we just need to figure out a way on how to change this mindset. Things are not going to be given or gifted to you, but you actually need to work hard to get it.
We don't need to come back to the caverns, man, the rocky age, but we need to start to do balance.
Absolutely.
That's it. Yep. Do you think the global medical community is using appropriate indications and prescribing testosterone correctly for men?
So I think the large part of testosterone therapy and testosterone prescriptions are actually not in the medical community, in the medical world at all. Majority of men that are using testosterone are using it from their friends, from their buddies, from their coaches. And so we still don't know the exact gravity or the total number of men that are actually using testosterone. Within the medical community, I think we have made significant improvements in trying to stick with guidelines on who should be getting testosterone therapy. We should be at least checking some blood tests before you give out testosterone therapy to men who have low testosterone. We should discuss some of the risks that can potentially happen with testosterone therapy. I think as the medical community, we're doing a pretty good job on deciding who to give testosterone to and how to follow. But unfortunately, most of the testosterone is being given in the non-medical community, which is obviously given without checking blood tests, without looking for any potential risk factors that the patients may have, and without any follow-up in terms of what is happening to their blood tests and any other side effects that they may have that may or may not need to get treated. So I think the testosterone therapy issue is less of an issue in the medical community and more of an issue in the non-medical community that we as doctors cannot really get a hand on.
When the testosterone therapy is necessary, which is your preferred way of TRT?
So the most common testosterone preparations that are available pretty much worldwide are either the injectables and or the topical preparations with gels and creams. The United States has the luxury of having the oral testosterone preparations that have gotten FDA approved in the last 5 to 6 years. And in Brazil and in some of the other countries, testosterone pellets are also available. But in terms of testosterone therapy indications, I'm always relying on the patient to tell me what their goals are. If they tell me their goals are, Doc, I have lack of energy, low libido, low strength, I'd love to go back to the gym and get some energy to go and exercise and look good, in addition to improving my drive and stamina and metabolism, then usually injections are a good option. And this is truly for the young population of men that have some of these goals. In the older population, where they're trying to get some energy, try to lose some weight, improve their insulin resistance, sometimes fix their diabetes, then testosterone therapy in the form of gels are much better. They don't really like injecting themselves once a week. I don't like the constant fluctuations that can happen with testosterone levels, especially in the elderly population. So therefore, in the younger population, I prefer the injections. In the older population, I prefer the topical preparations like gels and creams.
And a few years ago, the testosterone therapy in patients with prostate cancer was a nightmare and a clinical paradigm. Do you feel free today, nowadays, to use TRT in patients with active prostate cancer? In which cases do you do this?
So, testosterone therapy has now been shown not to increase the risk of prostate cancer. So, a few years ago, if you had a family history of prostate cancer, or if your PSA was high, or if you had an enlarged prostate, it was completely contraindicated. I think, given some of the large randomized trials that we have data from, we can say that testosterone therapy is safe for not increasing the risk of prostate cancer, for not increasing the risk of BPH, or for increasing the risk of PSA going up. However, testosterone therapy in men with active prostate cancer that has not been treated, I am still cautious. In people who are on active surveillance with a Gleason 3+3 or very low risk disease, I am comfortable giving testosterone therapy as long as they have very close follow up with both MRIs and PSA. However, in men who are treated for prostate cancer, doc, I've already had surgery for my prostate. I've had radiation therapy. It's been about 2 years and my PSA has come back to completely baseline or nadir. Then I am comfortable giving testosterone therapy. So I think testosterone therapy before the diagnosis of prostate cancer, completely safe. Testosterone therapy after definitive treatment for prostate cancer, completely safe. Testosterone therapy in untreated prostate cancer, we still have to urge caution and follow the men very carefully.
Do you think the recreational and abusive use of PDE5 inhibitors without proper medical prescription, or even based on recommendations from ChatGPT, like testosterone, is contributing to the increase in refractory cases of erectile dysfunction in young men?
With the advent of both online companies that are now prescribing PD5 inhibitors, regardless of proper clinical history, proper diagnosis, and access to PD5 inhibitors very easily, like you mentioned, even without a prescription from pharmacies in majority of the world, is definitely alarming. Number one, erectile dysfunction is, like you mentioned, a true diagnostic marker of any potential underlying endothelial dysfunction, like future heart attacks, future diabetes, future cardiovascular disease, which we could potentially all ignore just by taking a PD5 inhibitor. And at that time, maybe that erectile dysfunction may be fixed because it will work as a very good band-aid in most men. But we have lost the opportunity in that young man to diagnose potentially underlying medical problems such as diabetes, hypertension, cardiovascular disease, and cholesterol issues. The other issue with PD5 inhibitors is that men are getting access to this early on. And even men who don't really need it or don't even have erectile dysfunction or have psychogenic erectile dysfunction are using these drugs pretty easily and getting it pretty easily as well, like you mentioned. And if they start using these at a very young age, when they actually get older and actually need these drugs for their underlying erectile dysfunction, these drugs may not work. And when these drugs don't work, they're left with options such as injections, surgery for erectile dysfunction, such as a penile implant, and need to resort to much more severe and aggressive treatment options compared to using drugs alone.
How do you see the effect a lot of people self-using peptides, tirzepatide and retatrutide for lose weight without medical indication or nutritional follow-up?
So GLP-1 agonists have revolutionized the treatment of obesity. In the last 5 years, I think the number of drugs that we have access to, like you mentioned, tirzepatide, liraglutide, semaglutide, Ozempic, Mounjaro, have become very common. They've now gotten into the layperson's vocabulary. And so everybody knows exactly what those mean when you have a regular dinner table conversation with Ozempic and Mounjaro. The access to these drugs are still pretty limited. Thankfully, they still need a prescription. It's not very widely available. And so, therefore, to go through a doctor will necessitate both a prescription as well as proper and constant follow up. The retatrutide that you mentioned is a drug from Lilly that has been approved after the phase 3. Let me repeat that. The retatrutide drug from Lilly that you mentioned has completed phase 3 trials, but still hasn't received FDA approval. And people are getting it not through legal or medical ways and are accessing it. We don't have enough safety data on these. Certainly, we don't have long-term safety data on using some of these drugs. And so my best advice to those of you that are considering using GLP-1 agonists or the triple agonist with retatrutide, I think is important to get it through a doctor. Once it's available, obviously the Reta, but right now with using Ozempic and Mounjaro, to follow this along carefully. Because if there are some side effects that happen while using these peptides, you want to be able to go to a doctor and make sure that it's associated or not associated with the drug and not just ignore it, potentially leading to some adverse permanent consequences that you may not be able to reverse.
How do you currently view the global landscape of regenerative therapies in men's sexual health?
So regenerative therapies in men's health is sort of a new topic when it comes to just treatment of sexual medicine as a whole. In the late 90s, we discovered Viagra. In the early 2000s and 2010, we came up with both Cialis as well as Levitra, and then Stendra, of course, in 2012 with Avanafil that got approved. Since then, there has been no major advances in developing new drugs for erectile dysfunction and improving in sexual health. Regenerative therapies really started around 2010 with shockwave therapy, which is high energy ultrasound that can improve blood flow, that can improve erectile symptoms, that was started in 2010. And now over the last 15 years, we've moved from shockwave therapy that has very good level 1 evidence showing that it is both safe, importantly, for erectile dysfunction treatment, as well as efficacious, that it's now approved in the EAU guideline to treat men with mild vasculogenic ED. The newer regenerative therapies that have now come into play are PRP, P-shot or platelet-rich plasma, and stem cells and exosomes. The reason I mentioned PRP, stem cells, and exosomes in that order is that PRP, compared to shockwave therapy, has the second amount of data. So far, all of the studies have shown that it's safe. Some studies have shown that it's mixed in terms of efficacy, both positive and no impact at all. And stem cells and exosomes are fairly new, and we still don't have good data, both in terms of safety and efficacy for the treatment of erectile dysfunction. But I think this field is going to change a lot in the next 5 to 10 years, and we're going to see a lot more both data and widespread use of PRP, stem cells, and exosomes, along with shockwave therapy for treating erectile dysfunction.
Do you think that we are currently experiencing a paradigm shift from pharmacological medicine to regenerative Do you think that we are currently experiencing a paradigm shift from pharmacological medicine to regenerative medicine?
I think the era of drugs are still going to exist. Men are still going to have access to drugs like Cialis and Viagra and still keep using it. But we're now realizing that every time we want to think about sexual health, we don't want to be thinking about a pill. And so men want it as natural as possible. And so therefore, regenerative therapies are becoming more popular. And men want to have the natural ability to have sex as opposed to trying to rely on pills the entire time. And so I think the pills will still exist in our armamentarium of treating erectile dysfunction, But I think there is a slow but steady paradigm shift towards thinking about regenerative therapies early on in the course of a man with erectile dysfunction.
Yes, I think that our main paper in this scenario, that's we need to plus all the kind of therapies, the traditional pills, surgeries, injections, plus to regeneratives, integrative therapies like sensorial, psychology situation, distress function. Then we need to use all the tools that we can use and personalize for each one case. Erectile dysfunction, it's a hard disease to treat because it's multi-factor origins, and it's difficult to individuate and separate which is the cause, the main cause in this guy. Oh, this is only psychosis, whatever. Oh, this is only vascular, whatever. This is only hormonal. This is relationship troubles. It's difficult. I think it's an art to treat erectile dysfunction, and this is a high pen for the masculinity. Yeah, that is our paper. Oh, I only do pills. I only do proteins. No, I think we need to know about everything. I think the medical community needs to open the mind and be suitable to new knowledge and new therapies. Yes, but with ethics and evidence, we need to study, but we need to be open to heard about and study about.
Absolutely. I think the Hippocratic Oath says, do no harm. As long as all of these therapies are not causing harm, they don't have any adverse effects, side effects, potentially permanent side effects. I think the medical community needs to be open to both trying this and offering it to patients, telling them what we know, and more importantly, what we don't know. Not to offer false hope saying that this is going to 100% cure your erectile dysfunction, but to offer a good estimate of what they think success will be based on the personalized approach that you discussed. Because not every patient has psychogenic ED, not every patient has only organic ED. It is a combination. And sometimes we have to try some of these therapies to actually see what percentage is contributed by psychogenic, what percentage is contributed by organic, and try to see what can best make the patient and their partners happy.
There's no exam, there's no lab, there's no map that say that percent for us. And we need to be expert and experienced physicians to percept and this a good anamnesis and a good and we need to hear the patients.
So you mentioned that the modern therapies, they are individual, they cannot be massified. Do you think that is one of the key points that make it less accessible or less suitable for nowadays medicine? Because pills can be mass produced. You can open a factory and make infinite Viagra pills. But then you get a patient and he says, I want to be naturally treated. You can't just make a pill. You can't just massify a production of a product that heals him. Do you think that is, how much of a big roadblock is that to develop these therapies?
I think it's a huge roadblock. It is a roadblock because one, patients don't have access to these therapies as easy as pills can be, because you can go to a pharmacy and either with or without a prescription be able to get it. You're able to consult online with a doctor and get these pills and as a prescription and go get it. Whereas some of the regenerative therapies like shockwave therapy, PRP, and stem cells and exosomes are not widely available. And even if they are available, some of the costs are prohibitive. The pills are very inexpensive in majority of the world. And whereas some of these therapies are expensive and not all patients can actually afford it. And then if you cross the barrier of accessibility and affordability, and now you've come to a doctor who's actually offering it, we don't know if the doctor is actually trained to offer these therapies. Are they doing it because they just like it and they can do it? But are they actually trained to not just offer these therapies, but to actually treat erectile dysfunction? And most of the doctors are actually not even trained to treat erectile dysfunction, but offer these therapies because they can, and it is lucrative and is financially incentivized. And so I think patients are caught in this quagmire of not being able to access the correct treatment, not being able to afford these treatments, and not being able to receive it from the doctor or the physician who actually knows how to treat erectile dysfunction as a disease and not just offer these therapies for money.
Like you mentioned before, the great maxim of medicine, primo non nocere, Hippocrates speech, we need to remember that in great clinical trials, placebo almost have effects. 10%, 20%, 30% we seen when you study hypertension drugs. Oh, placebo treated 25%. Oh, it's a good. It's not the evidence is not used for it, but we need to remember that placebo it works, and because this is a human body, we are human, and yes, and erectile dysfunction are still a hard.
Absolutely. Absolutely. I think anytime we are looking at studies on erectile dysfunction, we absolutely have to look at the placebo arm because a lot of erectile dysfunction, like we discussed, is mental, is psychogenic, and placebos play a very big role in fixing that part of the erectile dysfunction. And so, anytime you're looking at a study for erectile dysfunction, you need to make sure that there's a placebo arm and not just look at the efficacy of the drug or the treatment alone.
Yeah. I'm a surgeon. I, I love surgeries, but when for us, we like to treat an objective treatment. Oh, I'll make a surgery, then I'll cure you, then I can take this disease away. But when the disease, when it's a human body, that the disease is origin when in hypothalamus, that's the Pandora boxes of our body. It's very complex. We don't know too much about this hypothalamus. That's the region that connects we with the world, with the light. Then we receive the sunlight. This is emits a radiation that comes to our hypothalamus and commands all your glands. It's complex to treat. Oh, tribulus terrestris, it's effective in testosterone levels. We know that this does not increase testosterone levels, but when we see our patients reports, I improve my erectile function when I use it, tribulus. Oh, I will not fight with this patient. Okay, are you feeling well with tribulus? Okay, primo non nocere, take away and go ahead using it. That's it.
Absolutely.
Where do you see the greatest advance today? Biologics, devices, genetics, or AI?
That's a difficult question. But I think with pharmacology and drugs, we are sort of have maxed wall that we can achieve with chemicals. I think we're done with that. In terms of biologics, I think we have transplanted some of the knowledge that we've gained from other specialties within medicine. I think dermatology has probably advanced the field of biologics the fastest and has shown that regeneration can happen. And because skin, we've always thought, is a dead organ, it's a terminally differentiated, you cannot really regenerate things like skin and hair. But dermatology and fields like plastic surgery have actually shown us that even terminally differentiated cells like skin and hair can regenerate. And so that gives us, in all fields of medicine, hope that if terminally differentiated cells like skin and hair can differentiate and regrow, why can't we go back and reverse some of the pathology that we see in organs like the penis and the testis? And so I think the role for biologics, at least over the next 5 to 10 years, with PRP, with stem cells and exosomes, is probably very exciting, given the fact that we have learned so much from dermatology and plastic surgery in regeneration, and trying to just apply that to another part of the human body that is probably more accessible, more amenable, and has the potential to regrow, I think is absolutely exciting. AI, I think, is absolutely going to be there in all fields of medicine, on all walks of life as we know it. Elon Musk, as we discussed, has said that surgery will become obsolete in about a few years. So, yes, I think AI and robotics are going to be there. I don't think we should be fighting AI and saying that we, as doctors and surgeons, will continue doing what we do. But we, at every step of our fields and every step of our career and every step of patient decision making, if there are opportunities to incorporate AI and robotics into our field, we should absolutely go and do it because it can only enhance decision making and individualized and personalized medicine, like you discussed before. It will never hurt the actual outcomes of patients.
That's it. You said that Elon Musk speech recently that in 3 years the community global medical will the robotics will do surgery better than our surgeon. And he's a prophecy guy. He's a visionary. Maybe a crazy guy. Maybe we are looking this happen too fast. I think that will occur, but in my opinion, I don't know if it will occur too fast. But he knows about the velocity of the technologies are going. This speech caused a polemic discussions in all community surgeon communities. The most conservators said that a crazy guy, that robots will not perform a surgery like a human surgeon. My opinion in this topic that's that I do think robotics will be better than the surgeons. Nowadays, we know that the robotics perform autonomous cholecystectomy in swine models, totally autonomous surgery. Cholecystectomy, it's an easy surgery, but it's not so easy. There are too many steps, and you need to process too many data. And when we think that the system depends on processing data, only this velocity of processing data. Nowadays, we live the era about binary system. Okay, binary system is like a O and 1, yeah, and this is bytes, megabytes, terabytes. I'm laughing, but it's true. You know
No, I'm
my
laughing
theory.
because I know you love that topic.
I
You love
love
it.
this topic.
He
Then
loves it.
I need to. I like to talk about this. Then we are living the area since 90s and in 20s, binary area, O and 1. Oh, one, too many terabytes. I don't gigabytes. That's okay. And this year we blocked with the quantic system computers. They will be too many fast that we can imagine the velocity. Then the the great jump that we'll see in the next years, we can imagine it, I think, and Elon Musk too. And I agree with him. Who am I in this world? But I agree with his opinion. It's too fast. If today is an exponential velocity of the development about technology, I think I don't know how is that where will go this curve of velocity of development, because the quantic system computers between 0 and 1, there are infinite possibilities.
So computers can compute fast.
But he can process this all data too fast that we can imagine. But if you take my MRI scans, my prostate is like this, and MRI is beautiful. It's normal, I think so. But if you use this data, MRI, with all data from surgery, robot surgery that we have today, I do think so. A robot perform a surgery much more safer and much more faster and perfect than the best surgeon of the world that I know. That's Vipul Patel. And I know a great surgeon that is a fellow about him. That's Rafael Coelho in Brazil. It's my friend and a great guy. It's my partner in surgeries. But I do think the surgery will perform by robotics experts in surgery. And me, like an old surgeon, I will be only a co-pilot. That's what I say. And I'll input a trocar in the abdomen of the patient and
Let the robot.
and let the robot and start a button, turn on, and perform now. What do you want to do? Well, my case is Gleason 3+3, or my case is a 3+4. And he will process all information better than me and 100 specialists together, assured of that. Which is the best treatment, the best surgery for this patient? No, it's a extended lymphadenectomy. No, the data are just numbers. And with the velocity, with the quantum computers, I think I never can think that my reflexes of my fingers will be better than this supercomputer that we can imagine today. I think like it's aviation. The most aviation crashes are human. I don't know the numbers, but sure it's over than 95%. Maybe 99.999.
Right.
Not to say 100%, but
Yeah.
okay, a machine is rarely. I think surgery will be like aviation. The pilot is just a coadjuvant in even faults. That's it. What I think. Do you think?
No, absolutely. I think with the advances in imaging, advances in technology that we have, and the ability to compute all of these things and get it properly in a data, the decision process that we as surgeons make in terms of the operative steps that are required for X, Y, and Z surgery, I think is fantastic. But the speed at which technology is developing, like you mentioned, the velocity at which the growth is happening, I think is absolutely mind-boggling. And it's definitely going to change the way we do surgery, we think about surgery in the next few years to come.
That's another reason that I focus on andrology.
Yeah.
Human urologist. And I can hear the pain, I can hear the depression, and I'm psychiatrist too.
You were talking about the quantum computers on the medic field, but that's just my view on the topic. But I believe quantum computing won't be as ground changing as we are talking, because okay, it can compute tons of data in much more faster than a human can or a regular computer can, but I don't know. I don't feel like it will change the way surgeons work. I think it would change the clinic field, maybe, because it can process all of the data, compare it to other patients, other cases. But maybe quantum computing wouldn't change surgery as much as you think. I don't know.
I think it will certainly change. So the way surgery is done now is you use all of the patient factors that we know, and we sort of plan it in our mind, step by step, on both the surgical steps, things to look out for, and then if something bad were to happen, what are the backup plan we have in order to complete a good and a successful surgery. All of this is done humans now, and not all surgeons have the ability to do all of the things that we mentioned in the same wavelength and the velocity, because different surgeons have different expertise. They've seen different experiences, they've operated on different patients, and the number of volume, we do know that more surgeries that someone has done, the more experienced they are and the better surgeons they will be. But I think quantum computing and AI, as we discuss it today, will take everybody to that level of an experienced surgeon. It will do the surgical planning for you. It will do, it will help, it will advise you on things to watch out for. It will advise you on what backup plans to have in case the surgery leads to unintended consequences. And I think that's where I think we will be better at, not just the actual surgery, not just the robot trying to do the surgery, but I think quantum computing and AI will help surgeons, especially junior surgeons, become much better, to have much better patient outcomes, because it will lay out a plan that surgeon may or may not have access to given his limited experience.
Okay, makes sense as well.
Because if you chat GPT now, I want to go have food, I want to go have Brazilian food in Dubai. Where should I go?
It's gonna search.
It not only
hundreds
tells
of
you ChatGPT and AI has gotten so advanced, it not just tells you these are the best restaurants to go have food, it advises you on where to park. It advises you on what dishes to get. It advises you on what the approximate bill is going to be. It advises you on what attire to wear to that restaurant. It gives you many more options than just go to this restaurant. These are the top 5 rated restaurants. And I think that's where quantum computing and AI will help surgeons. It's not only going to tell you this is how you do the surgery, it's also going to tell you the potential negative consequences that can happen, structures to watch out for while getting to this step of surgery, more personalized for that patient based on the data that has already been input.
Now, speaking a little about the techniques and therapies used in regenerative sexual medicine, what would you currently recommend for a patient that's very common in our routine? A patient with mild erectile dysfunction who still responds well to PDE5 inhibitors such as VEIGA and CELS, etc., but notice progressive worsening and wants to know whether there is any treatment that addresses the underlying cause and can potentially reverse this condition. It's a very common case in our routine.
Absolutely. So I think pills like Viagra, Cialis injections, intracavernosal injections are just band-aids. They don't really reverse the underlying pathophysiology of the erectile dysfunction or the Peyronie's disease, where regenerative therapies, even though have not been proven to be completely effective in all men suffering from this condition, I think have a limited role in select patients where you can potentially reverse the underlying pathophysiology by improving the blood flow, by recruiting stem cells, by recruiting and improving nerve function that can potentially improve endothelial function and smooth muscle regeneration. So yes, I think in men who want to have a potential cure, in potential reversibility of underlying pathophysiology, I think regenerative therapies offer an excellent treatment option compared to just using pills and injections that we know serve as just a band-aid.
Yes, I think the patients see this scenario. Oh, all day I need to use pills. Oh, I need increased doses, and when he goes to the urologist, the most then, no, this is the way. You only have pills. If pills are not okay, we will start to use injections. When you talk about injections, they be, why you crazy, doctor? When we talk about prostheses implants, it's okay. He go away and never go back more in our
Right.
in our point. Then, when we offers a potential therapy that can do this scenario backyards, in necessary, just stop the progress. I think that's a hope for these patients, the regenerative therapies. Then we need to focus the studies to find the answers that we have, which is the best therapies, which is really works, which are the protocols, which are the best energy, how is that we need to the scientific community and the specialists must be to look this with good eyes and study more a lot and wait answers, concrete answers scientifically with scientific publications. I think that's what we're gonna do.
Absolutely.
Despite the large number of papers showing the evidence of the efficacy of shockwave therapy and PRP in ED and Peyronie disease, what do you think is preventing the widespread adoption of these techniques as a standard of care in the urological community?
So there are many studies and meta-analyses that have been done showing the efficacy of shockwave therapy, both in erectile dysfunction, little less in Peyronie's disease because it has shown to improve symptoms of pain, but really not changes in curvature. PRP is a little bit more nascent. It has a few positive studies, a few negative ones as well. So we truly don't know its efficacy. And there is now more recent data showing that you combine shockwave therapy with PRP, and that seems to have an effect much better than just the individual PRP alone. Now, why hasn't this been adopted widely? For a few reasons. Number one, accessibility. Not all urologists, doctors who treat erectile dysfunction are offering these regenerative therapies. Number two, a lot of patients can't afford these therapies because they're obviously cost prohibitive and much more expensive compared to just using pills that are readily available and pretty inexpensive. And number three, I think probably the most important reason, we still don't know which patients are best benefited from these therapies. And I think the majority of the studies that have been negative have truly focused on treating pretty much all men with erectile dysfunction or all men with Peyronie's disease, not really subclassifying them based on underlying etiology. So I think the question is not whether shockwave therapies work or not, whether PRP works or not, but which patient population will it best benefit in. I think we need to think about this as a personalized medicine approach, not use a hammer and nail approach where we think there's one therapy which can potentially treat all men, but which best patients will be served by these therapies and offer it to them with realistic expectations so patients can both get trust back in the medical system and seek out these therapies if they do qualify for them.
It tracks back to that thing we talked about it not being mass producible. It needs to be individual. It tracks back to all of that, I believe.
Absolutely.
There are any papers published that they send a survey to US and Canada clinics asking about what clinics use this regenerative therapies or erectile dysfunction. And there are two main clinics that use PRP, that use shockwave therapy, and include the stem cells. But the most of them, about if I'm not wrong, if I remember, about 85 and 90%, they are not with urologic especially too.
Expertise.
It's only clinical and generalistic clinical treatments. What do you think about?
Absolutely. So I think urologists are either not interested in treating erectile dysfunction because they're too busy treating other urologic illnesses, or they want to treat erectile dysfunction, but that cannot offer the entire armamentarium of therapies that are now available for erectile dysfunction. And so therefore, clinicians, cardiologists, general medicine doctors, family medicine doctors, endocrinologists are now offering it. In fact, in the study that you referred to, gynecologists and non-clinicians sometimes are actually offering these therapies to patients. So I think it is time for urologists as a whole, as a community as a whole, to realize that we need to be treating erectile dysfunction. We need to offer all of these therapies to patients. We need to figure out which patients, which therapies would be best suited for, rather than patients going and seeking therapies from people who are not experienced in treating erectile dysfunction, don't really know the exact underlying etiology, and are just offering these for financial benefit rather than actual good patient outcomes.
Do you think if urology was a clinical specialty, maybe in a scenario, andrology, it's a clinical specialty, do you think this scenario could be different if it was a clinical specialty? Maybe the specialists would be more acceptable to these therapies, regeneratives. What do you think about? I think that because they are surgeon, as surgical specialty, I think that they don't believe this in fact. They don't want to hear about it. What do you think?
Absolutely. I think urologists, we pride ourselves in being surgeons. And so therefore, any non-surgical therapies don't seem to interest us as much. Any non-procedural specialties or treatments are not as exciting to us as actually doing procedures or surgeries. There is a specialty called andrology, which is a non-surgical specialty within urology that is present in countries like Russia, Indonesia, where people do medical urology for a few years and get trained in andrology as a subspecialty and do not get trained in surgery at all. And I think this specialty will continue to grow and evolve, not just in these countries, but pretty much to a large part of the world, given that now we do need a specialty within andrology that can treat men's health as a whole, all the way from hormonal manipulation to treatment of erectile dysfunction and testosterone deficiency, and for the entire lifespan of both adolescent, young adults, and older men. And I think we just need to think about this a little differently, rather than just focusing only on surgery. to think about non-surgical treatment options as well for men if you truly want to be interested and invested in andrology as a subspecialty.
That's it. I'm a surgeon and I think like a surgeon. The instinct of a surgeon is that if I can touch, if I can extract, if I can suture, and if I can do a knot, yes, I will solve it. But if I can touch it, if I can see it, if I can remove, I don't believe it. That's surgeon
Correct.
paradigm. I don't believe it.
Absolutely.
I don't believe in papers.
Right.
Papers accept everything that they don't believe. It's a great.
That would be why clinical fields are more acceptable about regenerative therapies, because they don't have the need to, physically go there, remove a cancer, remove a tumor. Would that be why clinical fields are more open to it?
Yes, they believe in theoretical therapies. They believe more in pharmacists. They believe more in psychology, in psychologist disease. They believe in the theories. Surgeons don't believe it. He needs to do to believe. That's it. We are where are we today with stem cells in sexual medicine practice?
So there have been a lot of phase 1 open label trials using both allogenic and sometimes autologous stem cells for treatment of erectile dysfunction. The studies have been very few in humans. Lots of animal studies showing improvements in erectile function, but in humans we have a few clinical studies. It has been shown to be safe so far. There are not too many side effects that we've seen. However, I think we truly need to determine the efficacy in treating erectile dysfunction with stem cells. Here in Dubai, we have the RISE clinical study. This is to use both stem cells and exosomes. So it's called regenerative injection of stem cells and exosomes for erectile dysfunction. And we are now recruiting patients with both severe and mild and moderate erectile dysfunction. We use a series of 5 sessions of shockwave therapy followed by the injection of either stem cells for severe erectile dysfunction or exosomes for mild to moderate erectile dysfunction. We've seen very good results so far in terms of safety. We're gradually accumulating data on efficacy, but I think well done, properly executed studies with both looking at safety and efficacy for both stem cells and exosomes are critical for moving this field of erectile dysfunction forward.
Which evidence is solid and which approach are still experimental in this field?
So as far as the AUA and the EAU guidelines are concerned, both stem cells, exosomes, and even PRP for that matter is still experimental. Therefore, we have to, as clinicians, use this under a proper research protocol with good patient counseling. However, as far as safety is concerned, studies so far have proved that it appears to be safe. But again, I think we just need to figure out which patient population this would best benefit and not just offer it to all patients who seek these therapies.
What regulatory barriers do you see around the world?
So, stem cell regulation, I think, is probably important. It is not easy to classify everything as stem cells. There's lots of companies that say that they make stem cells from blood, but we do know that the amount of stem cells that can be obtained from white blood cells in blood, even with pre-treatment, are fairly limited and likely to be limited in terms of efficacy for whatever it's used for. And so therefore, obtaining stem cells from bone marrow, liposuction, and or the umbilical cord are probably the 3 main sources of stem cells. In terms of the amount of stem cells that are grown, the number, the safety, to prevent contamination into these cells requires GMP laboratories at the highest level to make sure that it is safe. And so therefore, the regulatory barriers that surround both stem cell production, exosome production is high and should remain high. I don't think the standard should get lowered because at the end of the day, they're going to get injected into vascular organs like the penis. And so therefore, we need to make sure that they are safe before we can think about efficacy.
Nowadays, when, how, and who do you use stem cells in erectile dysfunction?
So in Dubai, as part of the RISE study, we're using stem cells for men with severe erectile dysfunction. So men who've undergone a prostatectomy and had good preoperative erectile function and have had acute loss of erectile function. we think stem cells can actually help recover the vasculature, the smooth muscle, and potentially nerve-related erectile dysfunction that can happen in these men. Exosomes are typically reserved for men with mild to moderate erectile dysfunction, where they're able to get an erection but unable to maintain the erection. And those patients' exosomes are probably sufficient. So, really, stem cells for men who have erectile dysfunction from prostatectomy, from severe diabetes, or an onset of ischemic priapism, where the onset of erectile dysfunction was pretty acute and can help hopefully recover some of their smooth muscle, vascular, and hormonal function.
Yeah. There are some papers that shows that there are some papers that shows that in prostatic cancers operated patients that we are not continent. The use of stem cells maybe is not a good option. Maybe this is in patients in prostate operate. They must be continent to try to use it. Do you agree with this, or you need more evidence?
I think continence and erectile dysfunction are. I think continence and erectile function are probably very important factors anytime we're counseling a man who's undergoing prostate surgery. Obviously, I think men want to achieve continence first before they can think about their erectile function. So I do agree that we do need to fix incontinence and stress incontinence first before we start thinking about fixing their erectile dysfunction. Sometimes it can happen both at the same time with surgeries such as artificial urinary sphincters and a penile implant that can happen at the same session. But usually men will want their stress incontinence fixed before fixing their erectile function.
Nowadays, when, how, and who do you use stem cells in Peyronie's disease?
So currently, we're not using stem cells for Peyronie's disease because Peyronie's disease is a disease of scarring and formation of plaque leading to potential curvature. Stem cells are primarily used for getting immunologically better to try and see if we can regenerate some of the vasculature and the muscles, which likely are not issues in Peyronie's disease. But I think in the future, I see stem cells for a role in the treatment of Peyronie's disease, where we want to prevent recurrence of disease. We want to prevent recurrence after definitive treatments like using collagenase injections into the plaque and breaking the plaque for future recurrence prevention. But as a primary treatment for Peyronie's disease, I don't think stem cells are a good treatment option.
Nowadays, when, how, and who do you use stem cells in male infertility?
So in men with azoospermia who have failed a surgical sperm retrieval, we are now offering stem cells as part of a clinical study called FERTILE here in Dubai, where we are injecting stem cells for men with Sertoli cell-only syndrome histology. So they undergo liposuction. It takes about 4 to 6 weeks for about 100 million mesenchymal stem cells to be processed in the laboratory, and then they are injected at an operative session into directly the rete testis under the microscope to make sure that the cells are able to get inside the tubules. So far, the data appears to be very safe. We've not seen any adverse or major side effects from injecting stem cells into the testis. However, it remains to be seen on which patient populations, based on underlying etiologies and hormonal levels, would best respond to stem cell therapy for azoospermia.
Are the peptides a new therapeutic frontier?
So peptides are definitely a new frontier in men's health. I think we've been used to giving out supplements for several years now. Hormonal therapy has been around for the last 20 to 25 years. I think peptides are able to achieve something that the supplements did not, without some of the side effects that hormonal therapies have. And so I think it's a very nice bridge between oral supplements and hormonal therapies. And we are yet to see the true expansion of how peptides can be used in men's health, and remains to be seen in the years to come.
Which ones have the greatest real clinical potential?
So the two peptides that are now FDA approved that are used in men's health are PT141. This is FDA approved. It's called bremelanotide, It is FDA approved for hypoorgasmic sexual desire disorder in females. We're now using it in men who have low libido but a normal testosterone level. The second peptide that is FDA approved for HIV-induced lipodystrophy is called tesamorelin. This is basically to lose central adiposity and belly fat. And for men who have obesity and have specific difficulties losing the fat around their belly, I think tesamorelin is a good option to use, even though it is obviously thought about using off-label. The most common peptide that is used worldwide is obviously the GLP-1 agonists with Ozempic and Mounjaro that is obviously used to treat obesity with or without diabetes. I think more and more peptides will get approved by the FDA and EMA, and I'm fairly certain we're going to see more of these peptides being used in both men and women's health.
What are the risks, potential misuse, and the lack of standardization of the peptides?
So, unlike drugs, pharmacologic drugs, hormonal therapies that have undergone the process of all of the clinical trials, proper phases, assessing the side effects, risks, adverse effects, and efficacy, peptides have unfortunately not gone through the entire life cycle. And so we still don't know the true side effect profile, adverse effects that can happen, risks, who to give it to, who not to give it to, contraindications for all of the peptides that are currently available on the market. And so therefore, we just have to be a little bit cautious in taking good, proper history, advising patients on what can and cannot be used, and not offer all peptides to all patients regardless of their potential side effects and underlying illnesses.
Let's do a quick rapid fire round about peptides, functions, and indications here. A rapid game. Let's do it. Are you ready?
Ready.
Let's go. Ipamorelin.
It's growth hormone releasing. It can help improve gain muscle mass, and the side effect is hunger.
Bremelanotide.
It's PT141. It can improve libido and sometimes cause nausea as the side effect.
NADH.
NAD can improve energy and metabolism. The side effect is this very short acting.
BPC 157.
This is bone protective compound. This is help to recover from long workout sessions and muscle pain.
Tesamorelin.
It is to decrease central adiposity and try to improve muscle mass.
Tirzepatide.
This is Mounjaro, and this will help lose weight and help treat diabetes.
Melanotan 2.
Well, that I don't.
I take hand. I wonder. One thing that you don't know. Sorry. Again. Oxytocin.
It can help improve libido.
Hetatrutida.
This is a triple G agonist. This can help lose weight without losing the lean muscle mass.
Thymosin beta 4.
This will help improve immunity.
Are you already using artificial intelligence in your clinical practice or research?
So we are using AI technology for sperm search right now in men undergoing surgical sperm retrieval. It is a difficult task for searching sperm in large amounts of testicular tissue. And so AI has sort of improved the efficiency of the process in helping us find sperm that otherwise embryologists may not be able to find. And I think it is here to stay, both in the embryology laboratory as well as in the operative specialty.
Tell me about your research line with AI.
So we're now looking at the chances of finding sperm in the ejaculate, called extended sperm search, where we are now using AI technology to identify sperm that would otherwise not be found with just manual searches, both with extended sperm search in the ejaculate, as well as using the AI technology to identify sperm in the testicular tissue after men undergo a microtesy.
Where do you see the greatest impact in diagnostics, research, or personalized therapies?
So AI, I think, will be there in reproductive medicine for a long time. I think we have to figure out what protocols will work best for couples in terms of getting the maximum number of eggs, not just quantity, but the best quality of eggs. And so AI will be there with figuring out hormonal stimulation protocols. AI will play a big role in the lab to both identify the sperm that needs to be used for fertilization, identify the best embryo that needs to be transferred, and obviously also help in identifying difficult cases where the sperm may or may not be present to help embryologists identify that sperm that can be used for an IVF cycle.
Can AI accelerate the discovery of regenerative treatments?
So I don't think AI can actually accelerate new therapies. AI is not an inventor. Humans need to invent. AIs can help discover. It can help treat men who need to be treated with the appropriate therapy. So it can personalize the medicine more. It can identify the best patients that will respond to functional medicine and regenerative therapies. But I don't think AI is going to accelerate the development of new therapies. But it'll help us identify which therapies will benefit which patients the best.
Is there a risk of erosion of clinical reason? Is there a risk of erosion of clinical reason, and how significant do you think this impact could be?
Clinical reason? I don't understand.
So the question is there a risk of erosion of the clinical reasoning, and how significant do you think this impact could be?
So AI certainly has gotten diagnostics and therapeutics to the forefront enough that it is now teaching patients on what blood tests to get, what diagnostic imagings need to be done, interpretation of those results when they come out, what surgeries should be recommended, what the operative steps are. And so patients are very well informed with both what diagnosis they have, what therapies they need, what imaging to get, what blood tests to get. And they're now coming and advising doctors on what needs to be done. And so I don't think it erodes clinical reasoning from the clinician standpoint, but it certainly has put patients at an advantage where now patients are very well informed even before they come and see the doctor. So the conversation between the patients and the doctor has become a lot easier because now doctors are also very familiar with what patients know and don't know, and the education gap is getting narrowed.
That's it. How do you see your clinical practice the next 5 or 10 years?
So the clinical practice, I think, is going to evolve a lot with AI and ChatGPT. And now ChatGPT is introducing ChatGPT Health, which is truly just for health information. And so when patients upload their results even before coming to see the doctor, when patients upload their imaging data onto ChatGPT and have a proper interpretation before coming and seeing the doctor, it's going to tell us, it's going to tell the patients what surgical options there are, what medical treatment options there are, even before they come and see the doctor. So I think we as doctors need to be ready to face that and not to fight them, and to go along with the patients and agree with them if we think it is right, and not fight this, because the patients are going to have gained trust in the AI system now, all the way from where to shop, where to eat food. And so therefore, they're going to trust the healthcare choices because it is giving them reliable information. So I think as doctors, we should just not say, don't Google this information. Don't look it up on ChatGPT. Let me tell you what the correct information is. Instead of fighting it, we should go along with it, agree with it, as long as we don't cause any harm and there are not any adverse effects, and agree with the patients and say that this is a good shared decision-making process, as opposed to just have this human versus AI fight.
Yes, I feel that you are a disruptive guy with great ideas, a great mind too. I saw that you developed an app called Urologic that to teach medicine students. Tell me about this.
Yeah, so
this entrepreneur.
So when I was studying for the urology board exam, I felt there were not too many study aids. There were these large textbooks and books and Campbell's Urology, which we know that people would go to and study for the actual exam. I wanted to make my life easier. And so I actually made flashcards from my entire study armamentarium as I was going through residency. And then when I finished my residency training, I said, how can I make this accessible to a lot of people worldwide? So I actually went out to publishers and said, can you publish this as a book? I will write a book called Urology Flashcards. And all the publishers rejected it. They said, we cannot do this because urology is a small audience. Not a lot of people are going to buy this book even if you publish it. And so all the publishers, at least the major medical publishers, turned me down. And so I asked my cousin, who was a programmer and an app developer, I said, can we put this as an app? And can I make this free? Because you could just put an app and make it free, because I didn't want to make any money from it, because I knew I wasn't going to make any money from publishing. And so we developed it as an app and made it freely available to all the trainees who wanted to study urology. And it is still to date available for people to learn from and to use it.
Which year was this?
This was at a time when apps were not even popular. So it was probably in like 2012.
2012.
Yeah.
You were 3 years
I
old.
was like free.
You know that that was a great idea. The great ideas emerge when we need to solve a problem.
Correct.
I need to solve a problem. I want to publish my ideas, my studies. Then what can I do? What do you think this? I think we will find the great application for AI in andrology.
Absolutely.
What are you thinking in your next studies? What are you thinking now? What can I solve? What's the problem that you want to solve now? And make a great idea emerge in your brilliant mind.
So I think we are facing a lot of problems because we don't know who responds to what therapies. We have a lot of therapies, but we don't know which patients to give it to. For example, Cialis and Viagra. We're giving it to patients. We don't know if they're going to respond to it or not. We have shockwave therapy, PRP, stem cells, exosomes. We're giving it to patients. We don't know if they're going to come back happy and tell us, doctor, you're the best ever or not. So therefore, I think AI needs to help us with this. It needs to help us get the correct therapy for the correct patient. I think we need to collect as much data as possible, because the more data we feed into the literature, the World Wide Web, the more AI is going to take from it and give us that answer. I think that's the juncture we are at. We are not in need of more therapies. We are in need of figuring out which therapies would work best for which patients.
That's the difficult today. And in 2012, when you had this idea, how long the time to develop this app? Oh, man, you contract how long till your app starts to?
So I think it took about 3 months for the first version for the app to come out. And then the app had a lot of glitches. It wouldn't flip sometimes. We couldn't scroll through. And anytime somebody went through like 500 flashcards, we had to go back to the first flashcard. We couldn't figure out a way to bookmark. And so we spent another 6 months to develop a second version of the app to make sure that, the reader and the usability is a lot better. So I'd say about 9 months to get the product.
It's like a pregnancy, 9 months. I show you this week the Manos AI. It can do this app in 10 seconds.
Minutes.
Yes, absolutely.
Try do the same. Do the experience, please. Try the same app that you
have
in the Manos. And
yeah.
I think 10 seconds, 20 seconds.
It will take minutes.
It's unbelievable.
It's a great tool.
We've come very far with technology.
It's a great tool for great minds.
Yes.
That's what I need.
Yeah.
I will be changed by AI. Your mind will not be substituted.
Yes.
We need the great minds.
No,
Your
correct.
mind is like the 1% of the world.
Yeah.
90% are hard workers. 90% are the physicians, the lawyers, the engineers. I learn a technical complexes, then I applicate these learns to solve problems. And just
that's
1% make great things in the world. They have great ideas.
They develop.
I have
the
a
data.
trouble. How can I solve? That is the big solution. Sometimes big business.
No, absolutely. I think people always say, how are you such a good teacher? Can you please teach non-urologic subjects to me, because, you're such a great teacher. The reason I'm a good teacher is because I'm not that smart. I always consider myself, I don't understand things very easily. And so I have to break some of these concepts down just so I can understand. Because I'm not that smart. I need to like understand it in a way that I can digest it and figure it out. And so when I teach, I usually teach it in such a way that I have learned it.
You taught it yourself.
Exactly. And so when I go back and teach people, I teach it in such a simple way because that's the way that I understood it. And if the concept is very complex, I don't even attempt to try and go learn it because I know I cannot teach it to myself. And so I don't bother teaching that either. So all the concepts that I teach are concepts that I have learned to digest and simplify it to teach it to myself.
That's it. Your mind and your brain are very fast to process informations. I saw this in 2-3 days. You can make too many things in all time. Do you have troubles with focusing, or do you think your thoughts are ghosts in your mind? They make traps for you. Oh, my thoughts I make me a nightmare. I need to stop to thinking. I need to relax my mind. Do you feel it or not? It's not a trouble for you.
Right now, I don't think I feel that too many things are happening at the same time. I think I can do them well, but I think as I get older, I think this would definitely be a problem. But anytime even though there are multiple tasks all at the same time, I try to do one task at any given time, and then I move on to the next task. It may look like I'm doing multiple things at the same time, but at any given time, I'm only doing one thing, and I'm focused on that. And then I move on to the next one. I move on to the next one. So sometimes I have to pause all of the other thoughts and just focus on one so I can finish it, so I can go on to the next. So yeah, it may be multiple tasks all getting done at the same time, but at any given time, my brain is only thinking one task.
That if you are telling this to me now, that's the reason. That's if you need to, I will need to do this only task right now. You surprise yourself with too many things and too many tasks. I'm not doing this very well.
Yes.
Then this is your
Focus.
defense mode no, I need to focus. That maybe it's a trouble for you too.
Exactly. Yes.
It's
Oh,
the
for sure.
great minds. Okay. Androgen. I get to another hour.
Yes.
Now I'm here. I will not thinking about this shit of this cell phone. Sorry. I try to pay it. Let's go. Androgen right now. He is my partner in my crazy androgen ideas. My wife can hurt me my thinkings about this educational problem because for me it's a disruptive career.
Yeah.
Practical. But
Yeah.
now I will try to be a teacher and learn. Well, I think it will go. And let's go. Observing the progress of the regenerative medicine in other fields such as orthopedics, sports medicine, dermatology, aesthetics, plastic surgery, and gynecology, this year we initiate the implementation of the Androgen Educational Project in Brazil. Its objective is to disseminate regenerative sexual medicine among Brazilian physicians, and specialties or not. The project includes the foundation of the Brazilian Society of Regenerative and Aesthetic Urology, with the International Board, Ministry of Educational Certificate Late Sensu Postgraduate Program, includes two hands-on workshops and immersive training programs, as well as other related scientific and educational initiatives that we think about. What motivates you, Dr. Randy, to become a partner in this project, Androgen Project, embryonary project in Brazil?
So I think we discussed that a lot of the regenerative therapies are available. We've discussed that they are efficacious in certain patient populations, not efficacious in all men with men's health conditions like erectile dysfunction and Peyronie's disease. What I think we did not discuss is the lack of education and awareness, specifically among urologists, to be able to offer these therapies. Because people who have trained in the last 5 years may at least be aware that these therapies exist. More than 5 years ago, they were probably not even aware that these therapies exist. And because these therapies are now being sought out by patients worldwide, they are now seeking therapies from doctors who are not really trained to treat erectile dysfunction as a comprehensive disease. And so I think I'm motivated by the fact that we need to create awareness among urologists, among doctors that are truly passionate about treating erectile dysfunction as a whole, and that can offer the entire armamentarium of treatment of erectile dysfunction, all the way from pills, injections, vacuum pumps, and regenerative therapies before penile implants to the men. I think that's where we are, and that's why I'm motivated that this society will truly impart education and awareness both among doctors and therefore among patients.
And that's the reason that we project and plan this educational program to not only for specialists, for urological specialists. We wanna to learn and training all physicians that are interested and are treating the erectile dysfunction. Then we can teach them what do not do, what is really, what is evidence, what is solid, what is just what is scientific and what is not is only commercial. I think it's our paper to touch this for community physician. This is the objective of under regime. How do you view hands-on training in regenerative medicine?
So I think the theoretical aspects are important, but hands-on training is very important because you want to make sure that the therapies are actually both safe and effective. The penis is not a simple organ. It has very complex structures with blood vessels, nerves, the urethra. And so therefore, you want to be able to make sure that the therapies that you're providing with both injection therapies, with PRP, stem cells, exosomes, and shockwave therapies are actually delivered to the proper place, both for safety and efficacy. So I think, yes, hands-on training is extremely a critical portion of teaching regenerative therapies.
That's it. I think the hands-on training is more important for the non-specialists because for as a urologic surgeon, the penis is his routine. But for clinicals and for gynecologists and everyone wanted to treat, he needs to know about how to handle this region. Okay. What kind of physician do you believe androgen will help develop?
So I think the physicians that are interested in treating sexual medicine should be thinking about getting experienced in regenerative therapies. I think urologists are definitely should be the forefront, should be the leaders within this specialty. But we don't have enough urologists to treat all men with erectile dysfunction with regenerative therapies. So I think if the field expands, doctors who need to get special training in who are in procedural specialties, who have previously done procedures and are comfortable using their hands to do procedures, will probably be the next best specialty to take on this role. People who have never done any procedures, who are learning procedures for the first time, need to be a bit more careful before you start doing procedures, because now you're doing a part of medicine that you've never done in your whole career, such as gynecologists who've been operating on and treating women their whole life. Now they want to try and get into this specialty. I think you just have to be a little bit more cautious before you jump into this specialty.
Yes, I think with this project, we will avoid that the therapies that are not available, that the therapies are not scientific evidence, have not evidence therapies, will not defund. We need to defund the therapies that are efficient. That's our paper. And train these clinicals that are interest, because there are great commercial interests in this area. It's a great pen about the population. Then is our paper to teach these professionals. Okay. What do you expect from this partnership in the medium and long term?
So I think the partnership will grow global awareness, both of the presence, availability of regenerative therapies. The partnership will expand access to learning, both hands-on and theoretical training for doctors who are interested in learning about male regenerative therapies, and specifically to try to enhance collaborations in research, partnerships in getting and gathering data to figure out which therapies would actually best benefit which patient population.
Okay, I expect that growth, and we can do with purpose, and and let a legacy in this area in Brazil and maybe the world. With your partner, I think we can
An
range
aim for the world.
we can range the all worldwide. That's it.
I believe you already talked about your trajectory, your career journey. Okay, so okay, with that out of the way, I can ask my questions. So first of all, I was thinking about the language barrier between India and the U.S. because he told me that you're from India, right, and you moved to the U.S. to study and work as a physician, and it got made me thinking, how did he adapt into English? Like, did you have any roadblocks? Did you hit any? Uh, I don't know. Was it a difficulty to you to adapt into English? How was it?
So thankfully, the primary medium of instruction is English. So in school, in most schools in India, English is the main language. So you learn all of the courses and subjects in English. Thanks to the British influence, India got independence only in 1947. So over the last 60 years, English has been the primary, in fact, official language in most states within India. And so learning the language itself wasn't difficult, but the hardest part was the accent. So when I initially moved to the United States, I spoke English very differently compared to the Americans. And so adapting to that was not easy. And so you knew the language, you knew how to write it, but when you spoke it differently from the rest of the community. But thankfully, I found enough friends and a community that were from India. And so that helped me adapt culturally and slowly assimilate into the culture. I did not want to pose myself as an American. I did not want to pose myself as someone who knew the culture, knew the language. We did not have as much access to social media, music videos, American TV shows growing up as kids these days do. And so, therefore, adapting to the culture, assimilating to the culture took a long time. But in retrospect, I think it was a good idea because now that I've moved to Dubai, I know how to adapt to different cultures. Bit more challenging when you move at a later stage in your life than when you're younger, but certainly not that different.
Yeah, so we could spot that your biggest difficulty was on the speaking it naturally. Could we say it? Yeah. In fact, I work as an English teacher on an English startup I started last year, and I have that feeling that most people actually they can write in English, they can learn a second language, but the problem is you can do it naturally. You can incorporate that into your life. I believe that's the key to learning a second language. And the other questions they are regarding of religious matters into the fertility field because it's a delicate field. Like it's hard to separate it from beliefs and ethics. So it got me thinking. What is my father told me, correct me if I'm wrong, but I believe you are a Hindu, right?
Right.
Is that correct?
Yes.
Okay, so he's not wrong. What are your religion's beliefs on fertility treatments and sexual health? Is it too different from the Christian point of view? Because as Christians, our view is mostly pretty much open to this kind of treatment. So what is the Hindu perspective on that?
So I think the Hindu Christian beliefs in terms of reproduction are actually fairly similar. They're not very different. Some true Catholics believe that IVF, taking gametes out, taking sperm out, taking eggs out, and doing IVF are actually not allowed and prohibited. And so, in that sense, I think Hinduism does not prohibit doing IVF. It's absolutely recognized and acceptable to perform IVF and fertility treatments. Now, coming to Dubai, I'm obviously exposed to a majority of Muslim patients, and their beliefs and ethics and the rules here in Dubai are quite different when it comes to using donor gametes. So, in the United States, in India, in majority of Europe, South America, if you don't have sperm, if you don't have eggs, the use of donor sperm and donor eggs are actually widely available and acceptable by the patients and the society as a whole. Whereas in the UAE and in Dubai specifically, donor gametes are not allowed. So you cannot use donor sperm, you cannot use donor eggs. In rare cases, medical surrogacy is permitted. And so therefore, adapting to that mindset and belief has been a bit of a difference for me. I wouldn't say a challenge, because now it's challenging on our end, because now I need to make that much more effort to find that sperm, because the chance of them having a child is only through biological parenthood. It is not through third-party parenthood. So therefore, that belief within this culture and the religion as a whole is different, and I'm adapting to it. But as far as Christianity and Hinduism is concerned, it's actually fairly similar and widely acceptable, not just to do IVF, but even to use donor gametes as a backup.
See. You moved here into Dubai. It's not been a long time, right? It's kind of recent. So most of the time, we could say you raised your family, you raised your career in the US, right? So did you face any problems or other roadblocks regarding your religious beliefs in the US during your career, or work peers or family matters? Did you face anything like that?
So the United States is a truly secular state. I mean, it's an immigrant melting pot, especially where I trained in New York, in Texas, Florida. It's a melting pot. It is widely okay to follow whatever religious faith you want, to follow whatever community beliefs you want, and so therefore, I truly didn't face too many barriers in terms of not just practicing my own religion, but also to raise our kids in the same religion as Hinduism as we were. And so the not too many barriers you face on a day-to-day basis. As a society as a whole, I think the country itself is changing by a bit now. We don't know how it's going to change in the next few years. But I think as far as secular beliefs, both within the United States and even here in Dubai, you're absolutely welcome to practice your religion, to follow your community beliefs, and to live in a secular society.
What projects are you currently working on?
So the some of the most exciting projects that we are working on for research are to solve the azoospermia problem. We don't know why most men don't make sperm. We don't know why sperm counts are declining as a whole, both in the society and with aging. As men get older, we think the sperm count should remain stable, but it is still going down. And I think the more and more we uncover the puzzle of why sperm counts are going down, why production is decreasing, I think we'll be able to solve a lot more problems. Right now, the cause is unknown, and so therefore the treatment is unknown. And so the more and more we discover the causes, the more and more we can offer treatments for this population of men.
And if you have a trouble, you will find a solution. I'm sure of that.
Yes.
Keep trying,
Yes,
trying.
yes.
And using your neurons and your brain, the
Yes,
ATPs on
yes.
this trouble, big trouble. The human sexual, grateful for this. Okay. Are there any promotional trials underway?
So the two studies that we discussed already are the fertile study in azoospermia using stem cells and exosomes. We're doing the RISE clinical study for using stem cells and exosomes for men with erectile dysfunction. We are doing the AI study, where we are now looking for sperm in the testicular tissue after men undergo sperm retrieval procedures. And we're launching two other studies. One is to specifically look at something called gonadotropin reset, where in men who have very high FSH, LH levels, we're trying to see if we can make it normal using either a combination of HCG and testosterone therapy. And finally, we're trying to see if we can use stem cells in Peyronie's disease in combination with collagenase to try to see if we can decrease the rate of recurrence.
Too many line of research. Great. Too many studies and work a lot. That's it. Is there any disruptive technology that's not yet on the public radar?
No, I think we have all the technologies we need. We just need to identify which patients would best benefit from which technology.
That's the point. We need to solve it. What is good for who
Yes.
and
For
when
which
and
patient?
how?
Yes.
What excites you the most scientifically today?
So I think the majority of the men that have no sperm at all are left with saying you cannot become a biological father. And that is a very frustrating problem. And I see several men with this, especially in this part of the world where donor sperm is not an option. It's very frustrating. And so that's what excites me the most, is to try and uncover the puzzle of why do these men not have sperm, and try to see if we can offer any therapies that would even get them that small but significant chance of a biological parenthood. Like you mentioned, it's binary. It's 0 or 1. It's either a child or a no child. There's no gray area. This is not a spectrum. And so I think anytime we can convert that 0 to 1, I think it's a huge success for us, and that's what excites me every day.
In your personal vision, how do you prophesy or do you visionary about andrology in 10 or 20 years? What will become obsolete? A personal opinion without scientific. What do you
So
think?
I think in 10 years, andrology is going to shift from just treating erectile dysfunction. You have Peyronie's disease, you have testosterone deficiency, you have obesity leading to this, and more of a global men's health specialty. Andrologists are going to become the gatekeepers on the forefront of treating men as a whole. This is not just I'm going to treat your ED, you go see all these other diseases for someone else. We're going to be focused on longevity. We're going to be focused on regeneration. We're going to be focused on trying to optimize hormones, optimize blood levels, rather than just treat the blood tests. And so I think the field as a whole is going to change. It's very narrow right now. You have erectile dysfunction, you take pills. You have Peyronie's disease, you need some injections. To more of, let me optimize all the other things, and maybe these diseases will solve on their own with just a little bit of help. And I think that's where we are headed to. And I think we in andrology need to be aware that that's going to happen, and think about the patient as a whole rather than just this narrow focus spectrum.
I agree with this. What will become a standard practice, in your opinion?
I think trying to use regenerative therapies will become standard practice in 5 to 10 years. We just need to figure out which patients this would become standard of care for. Even before right now, we're giving out pills as a first line for all men with erectile dysfunction. I think we're going to move the regenerative therapy paradigm more earlier in men with erectile dysfunction, rather than wait for taking pills, failing, and then coming to offer these therapies.
I agree with this, that we know that the erectile dysfunction is a vascular disease, and we know that the guy that have erectile dysfunction, he is the first signal claim of the event cardiovascular in the
disease.
future. 3 and 5 years, he was heart attack or an AVC. That's a vascular disease, and I think that will be less specialties and more clinical practice. That's I agree with this. Okay. What legacy would you like to leave for sexual medicine or for the mankind as a whole?
In terms of legacy, I've always wanted to be the first to do something, the first to, and then you can fill in whatever blank you want. And I hope to have a lot more firsts. I've had a few firsts, but I want to have a few more firsts where I say he was the first to, and whatever blank you want to fill in, I think is totally fine. But I've always taken a lot of pride in doing the first at something, coming up with an idea, executing it, designing it, and making sure that that comes to fruition. So that's the legacy that I want to leave behind, that he was the first to, and then you can fill in whatever blank you want.
Yes, I need to contribute with anything. Let's not be the first. What advice would you give to young physicians who want to enter in this field?
So the biggest advice that I have for people, doctors who are considering entering into andrology, entering into urology, entering into regenerative therapies, is to keep your mind open. Don't just be looking at guidelines, looking at textbooks, looking at research, and saying these are the only things that I can offer you. But to think about patient problems. There will be people complaining to you the whole time, reporting problems that you don't have solutions for. Think about that instead of dismissing them and say, we don't have any therapies to offer to you. And try to see what you can do to uncover that small yet significant piece of the puzzle.
Which book or mindset has most impacted your career and your decisions?
I think the mindset of resilience, the mindset to never give up, I think is probably the most important that we as doctors and clinicians and surgeons should possess. The minute we give up, we should stop working. As long as we don't give up and stay resilient, no matter what hardships happen, because life is going to have hardships. It's never going to be easy. Nobody, even Elon Musk, who has succeeded as much as he has, can tell you that he did not get there easily. He must have had many hardships and will continue to have. But I think resilience in the face of hardships is probably what differentiates successful from not so successful people.
That's nice. A take-home message for Brazilian and Latin American physicians.
So I think Brazil is a very large country. It has a lot. I've been there a few times. It has a lot of smart doctors, smart urologists who are willing to push the forefront of medicine. I think they should not just follow guidelines set by the Americans, by the Europeans, and sort of figure out what best would work for their patient population, what therapies can be available within the regulatory framework of their country, and figure out how you can best tailor medicine therapies for Brazil and Latin America, as opposed to saying these are the guidelines that are set by the professional societies and these are what we're going to follow. Instead, come up with your own set of guidelines, your own set of framework on what therapies work and don't work within the Brazil and Latin American community, and establish those and set those guidelines and follow those guidelines and be a forefront on innovation, research, and coming up with the latest technologies and the treatments for the patients.
That's it. It's a warm community, the Latin people. I think they are more human, maybe. They're not so cold like North America and European. They're less techniques.
Yes.
We call Brazilian jeitinho, the Brazilian way of life.
Yeah.
Okay. Final message. Dr. Randy Ramasamy, thank you so much for this incredible, rich, and inspiring conversation. What became very clear today is that andrology is not simply evolving, it's undergoing a true paradigm shift. We talked about science, evidence, responsibility, innovation, medical education, technologies, and most importantly, real impact on patients' lives. That's our goal. This partnership that begins today and this week through Under-Regine Educational Project represents exactly that vision, building a new generation of physicians prepared to work at the frontier of regenerative medicine with scientific rigor, ethics, and clinical excellence. I always said that regenerative medicine is a delicate journey, walking on eggshells and through thorns to finally reach the rose. I truly believe this is only the beginning of something much bigger, a movement connecting Brazil and the world, research and practice, knowledge and transformation. On behalf of our medical community, thank you for your precious time, trust, leadership, and your visionary thoughts. And of course, your humble personality. Thank you very much.
Thank you.